you fixed it through it.
And springtime crowded every time. Anyhow, so that it gets in the way too, and probably should go down there. Plus, I haven't skied this winter, and that gives me an excuse to go down. So the real answer is probably not. Yeah, probably. I do want to go to Disney World. I go without it. I get. You remember the time we went on the Disney cruise? Yeah, that was great. Yeah, we went for 3 days on our own before that and hit all the different parks, including main Disney World one. We got a lot of the minor ones, and that was not the cruise, so that was the great trip. That's the last time I've done this.
We did have actually kind of the
no, those are the good old days.
still have
Yeah, so we put drug.
She takes one measure on this.
All right.
I just want to tell you that this Fungus condition is just
You might find some questions and things.
Yeah.
Just got fired. Company made some acquisitions.
no, you can't beat it into something.
Oh, okay. I met you before, I think earlier, but. Okay.
I was something I seen her.
No,
She said she's got an
I think we're gonna try to have a follow-up meeting.
You gotta look at it that way.
It's a glass half full.
No, I think this one's about an 1/8 full. I don't think it's a half full. Don't you know you're retired, Kennedy? You don't have to come here anymore.
You know, I'll get used to it. I get, you know, I'll figure out something else to do.
Breakfast is not worth coming just for breakfast.
Well, it all depends.
Depends on what we're at. I was just going to see if Matt's here. I got another patient.
How are you? All right, I think.
And he wants to see us got some weird immunodeficiency. It's not just celiac. I said, oh, yeah, let's see Matt. So he calls up and says he's not seeing any patients. He calls up and says he's not seeing patients. He lost his scheduler, so nobody else will schedule. So they're saying he's not seeing patients. It's like, oh, you might be able to.
I'm here.
His wife is one of our surgeons. He's one of these guys.
People are already on mental, and I don't want to take my right.
He's never really been sick, and now he's not getting better.
Nurse.
So, he said I could.
I think it should be an issue.
It's not a bad idea. Admittedly, I'm still writing for the role of nurse.
So I'm going through all my stuff, trying to just think of photographs.
Are you going?
Yeah, I mean,
Yeah, but what
I haven't seen Steve because he's still.
Yeah, no, it's cool.
This is my we had also met with
There's some a little bit of a hiccup in the finances for
one is for
I asked Sue when she's going to be in that night. She goes, no. So it's only been 12 years now, so
maybe find some information in there. I know she found a couple pieces in there really helpful. So yeah, I have your email. So
yeah, I know the doctor.
if she confirms after.
she says she's coming down. And then we got
exactly. Maybe we might have to run for it today, but let's find out.
Okay. Okay.
Hey, how are you?
All right. Thank you.
Sue's fun, there's no difference. To make it ready for Because I think she's up there in the winter on the island. She's there
Oh, that was very cool.
she got hurt. Somebody
And it
knocked
was
her.
their originally stated.
Exactly.
Yeah, the neighbors used to find her and ended up flying her out. But she didn't have her phone. She couldn't move. Then she wrecked her shoulder with the spider. Has to be basic science.
You especially.
Not necessarily.
And the same content as the
Why you didn't work, but you're, I'd like to go to the big guy.
Every time I go there, I get something.
So I don't have one. He said, hey, you don't need to be married in May. So,
Chip off the lot.
And I'm not sure. Having heard that,
Yeah, exactly.
but you're doing like genetic stuff, like that's not necessarily just
Yeah.
clinical.
Yeah, but I don't think any of the stuff I'm doing is basic.
It's not like in a lab.
Well, I don't think, unless there's something that's like well on its way, I'm not gonna publish like a first author paper from doing it. So I'll get to see some things being in a lab.
Yeah.
So
One year cold shoulder for 2 days.
So I would just talk to Bill.
I see Carly's out.
he's back DNA.
Yeah.
So what did you do? How did you get to
Let's still go.
Oh, yes.
We're talking that.
I asked her.
But you can do a side step and stuff that like a smaller project that like you might really be small. Yeah. I think one of you guys.
No, I'm kind of gonna do my job, but you know, how I change the subject. I've been doing 34 years in presentation.
Yeah, I think Lisa did it.
So,
Going to politics.
You might want to talk to
it's
Lisa.
like, do you know how to like pet a
Everyone are conservative.
He was like, have you ever been in a
That was
basic science lab?
I talked to
I need a picture of you and
David
Bill.
Rawlings
and
that
then-
children, and he was kind of in the beginning, he was kind of receiving what's their expectation
I got Van Arsdale's picture.
how many years do you intend to stay here? His you're only going to be for one research.
I got
There's
oh, I
more
got
probably in his lab than actual.
But it'll be great.
You can like enroll your patients and like,
I should be able to get it from Jimmy. I didn't even think about it.
no, I don't do the phlebotomy. Like, can I work do a project in like 1 year where I'm like enrolling my own patients and then also working in the lab with the studies? Like, is that?
I don't
So
think so.
Word of the day.
Sunday morning, they didn't open any of the doors, so there were 2 hours of
I don't remember. It was the beginning of
in the
first
rain.
year.
So by the time I got to the top,
Yeah.
I couldn't do anything. It was so heavy on the bottom part, I couldn't even turn.
All right, let's go ahead and get started this morning. A number of our colleagues are in Hawaii. There's a West Coast allergy meeting that's on Maui. But they're not up yet. It's only 5 o'clock in the island. We're short one fellow. Don't tell me we let fellows go on vacation. Is this a new thing, vacation? We never had it, right? We worked every other night. 365 days a year. So, Markus, we switched the speakers this week and next week just for their mutual convenience of presenting. So Markus is going to talk to us about, you can see the title as well as I think, dermatologic complications of primary immunodeficiency. So thanks very much.
Thanks everyone for inviting me back. I'm always happy to be here. So we'll get started. Since the last time that I met you, I have a new disclosure. So I'm involved in the dupilumab trial at Children's. Right now we're looking at kids that are 12 to 18 years old. this doesn't really have a whole lot of relevance to this particular talk, but it's also a plug because we're slowly going to be moving down to earlier years. So if you have kids who you see that you would like to get involved in this trial, feel free to email me. We can kind of get them on a list and reach out as soon as these next phases get ramped up. So the objectives today, so we're going to be focusing on fungal infections, and dermatophytoses and candidal infections are a very common presentation of multiple immune deficiency. So the first thing that I want to do is, again, just kind of take a step back and looking at the skin and kind of being able to identify, is this something that I should be worried that it's a fungus versus other rashes? And then kind of understanding what things and what presentations should make you consider a primary immune deficiency, and then hopefully learning how to take the first steps in treating these fungal infections. And as always, I like my style to be a little bit more informal, so if you have questions, just really feel free to shout them out or raise your hand, and we can kind of go through things together. All right, so I'm going to start with Candida, and this is a presentation that I see very commonly in my peds derm clinic. What you can see in the upper right-hand corner there is a typical candidal diaper dermatitis. And lots of times children come in with rashes in their bottom, and the thing that really makes this stand out as a candidal dermatitis is that what's involved are the inguinal folds. So you see this really beefy red erythema, and then these satellite pustules that are spreading out from that area. Those two things together, so exclusive involvement of the folds that are then kind of spreading out there with satellite pustules or little red papules is a slam dunk classic presentation for a candidal diaper dermatitis. The other place that we commonly see Candida in dermatology besides in the oropharynx with candidal thrush is you can get a paronychia. So paronychia just refers to inflammation around the nail bed. And when we see acute paronychia, that's typically a staph infection. But when you have this chronic low-grade erythema that can be a little bit tender but not exquisitely painful and just seems to be ongoing and ongoing, then you should consider Candida as well. And you can see that in this particular child, there's been lots of dystrophy of the nail plate itself, and that's just from all the inflammation that's going on at the base of the nail matrix that's causing that discoloration and dystrophy of the nail itself. And this is just what Candida actually looks like under the microscope, so sometimes we do scrapings, and you can see there's a bunch of little yeast forms that are all stuck together. In addition to Candida, the other thing that I see commonly in the skin are dermatophytoses. So this is the jock itch and the ringworm and the Tinea Capitis. So basically these are all the Tineas. And we're going to go through a number of pictures here. We're going to beat this point home. But the key with these is that you're looking for an annular morphology. So these have a nice ring around them. And then typically there's some degree of central clearing as well. When you see that pattern, you should be suspicious for a dermatophyte infection. There's lots of other things that can mimic these. If you see complete involvement, then that you might be dealing with nummular eczema. So if you see this redness and scale that goes throughout the lesion, then there's a little bit of a differential there. There are other inflammatory disorders such as granuloma annulare that also assume a ring shape to them. The thing that distinguishes tinea from these others is that there's a raised border that has some scale with it as well, and we'll show you some other pictures of that. But that should be the thing that really clues you into that. So if you're looking at this and you see that it's a ring, but you're not feeling any flaking or scale over the surface of it, it may not be tinea. This is another example. So you can see here that it has a nice annular morphology, and then inside there's a little bit of clearing, but what you're also seeing is that there's a decent amount of involvement inside. So thinking that this might be an eczematous dermatitis is not unreasonable either. Based on the history, what Mom said is that there was a small spot that continued to grow outward from there, which can be consistent with tinea as well. But sometimes in hair-bearing areas, you can see small pustules and papules, especially around the hair follicles themselves. So this kind of increasing induration around here is also suggestive of tinea. But the thing that really makes it makes that the diagnosis is that if you look up here, you can see that there's faint scale around as well. So this would not be something like granuloma annulare. I really like this picture because this patient did have granuloma annulare previously, and it was unresponsive to therapy, so I put him on a course of pred and cleared his granuloma annulare, but then instead I gave him tinea ACI. And so when Mom came back, she's like, his granuloma annulare is back. And I was like, no, this is actually something different this time. And again, the key was that there was scale throughout.
Is it typical
Very little hair in the eyebrow there?
Yeah, so his eyebrows started to fall out from the inflammation.
Is that typical for the hair to fall out when it's around the
Yeah, if there's that degree of inflammation, then yes. So here's another example of Tinea Capitis. So you can see this is a little bit more of a classic appearance where you have the nice annular look, the red rim around it. You can tell just by looking that there's a raised component to it, and a little bit of scale that's a little hard to appreciate in the picture, but was there in person. And again, this is something that ended up being a tinea infection. Again, kind of expanding the differential, when we see annular lesions on the face of an infant, so this baby was about a month old when we saw them, and I think the important thing to remember is that we often think of tinea infections and jock itch and Tinea Capitis as being a condition of adults, but even young children can get it. But in children who have annular lesions on the face, you also have to consider neonatal lupus. And so that was something that we ruled out as well. But again, that was thought less likely initially because of the degree of scale that was present in these individual lesions. This is even yet another example of tinea corporis. So this is jock itch. So this is tinea cruris, and you can see in this instance, what makes it a little bit different is that it has a polycyclic look to it. So you can see that there's sort of the beginning, the leading edge, and then there's kind of just waves of more tinea progressing outward. Here's another nice lesion. You can tell there's a little bit of substance, a little bit of flaking over the surface with central clearing. This is another presentation when it's a little bit more widespread and fulminant instead of just an individual annular lesion. In addition to ringworm or tinea corporis on the body, another place that we commonly see tinea is on the feet. So this is a more classic type of Tinea Capitis, where you see that maceration, there's scale, and the skin just looks kind of eroded and crusty, and it's centered around the interdigital spaces. Again, this is going to be a place where it's wet, it is dark, it's going to be a great environment for fungus to grow in. And so this is often the place where you'll find tinea if you're suspecting it on the feet. What I have over here is a different type of Tinea Capitis that we call Markus in distribution. And this can actually be, you have to have a certain degree of clinical suspicion for it. When you look at it, there are little areas where the skin is kind of like round and denuding, but oftentimes patients will come in and they'll think they just have dry feet. But this is a type of tinea where basically the entire sole and the lateral surfaces of the feet are involved with just this dry, fine flaking and scale. You can see there's some background redness as well. So when you see that, that may also be a manifestation of tinea. Okay, so the treatment for all of these is basically just topicals. And typically, I like ketoconazole the best in young children just because I'm a little bit of a conservative and nervous person. I often will give them clotrimazole. We don't like giving ketoconazole systemically because of the risk of hepatic failure. And I think, well, clotrimazole, if by chance the family were to use enough that you could get systemic levels of it, that would be a little bit safer. Topical terbinafine works as well. The one thing that I would say about this also is that it's often helpful just to culture and treat, or culture in addition to treating, just so that you know what you're dealing with. One thing that typically happens when we get referrals is that providers will order a fungal culture. What you really want to make sure that you're doing is ordering a dermatophyte culture, because fungal cultures will sometimes grow species that are just kind of incidental. So we all have things that grow on our feet that are not pathogenic, and it's just because you were at Gasworks Park and you were walking with bare feet, and then you'll be growing these like Rothia species and other things. So it's really helpful to select the dermatophyte culture instead of the fungal culture, because oftentimes we'll get calls and they're like, well, it's growing the species, do you think that I need to treat it? And typically it's not something that's infectious. When patients who have primary immune deficiencies, all bets are off, but we can talk about that a little bit more. In addition to its manifestations on the skin, we know that fungus can also affect our nails. This is an example of onychomycosis. And what you can appreciate here is just this complete dystrophy of all of these fingernails. So instead of having a nice, even, translucent border, you can see that there's ridging and this whitening of the nail plate itself. You can tell that the nails are getting thinner as well. So this is a very good look for onychomycosis. For treating this, the key, again, is sending the nail for fungal culture to make sure that you have the right diagnosis. Oftentimes, we will see patients who have psoriasis. Lichen planus is another systemic condition that can give nails that have a lot of dystrophy and some white change to them. And so that often gets confused for fungus, and we'll have patients who have been on 6-12 weeks of terbinafine for something that doesn't need it. And so I think for when it comes to nail dystrophies, the first thing that I always do is send for a fungal culture, unless I'm absolutely convinced and there's other manifestations. For instance, if there's rip-roaring Tinea Capitis in the context of the onychomycosis, I'll go ahead and treat at that time, but typically I wait for the culture to come back. As far as treating, we usually reach for terbinafine as our first choice. And as far as monitoring it, this has become a little bit more controversial now in our field. So historically, people would get an ALT because of the concerns for hepatotoxicity with systemic terbinafine. And so we'd get a baseline ALT, and for treatment longer than 6 weeks, we'd get another one at the 6-week mark. There was a recent article that came out in our JAMA Dermatology that questioned that practice because the sort of hypothesis was that the risk of hepatotoxicity is very much overblown with use of terbinafine, especially in limited use settings, so for just 1 to 3 months. And the conclusion of the authors was that you don't really need to do that unless there's other comorbidities in those patients. So if they already have some sort of liver disease, if they're obese and may have non-alcoholic steatohepatitis, things like that. When it comes to kids, we definitely still do it just because we're a little bit slower adopters, but I don't get too worked up about the ALT. As far as treatment, the adult dose is 250 milligrams orally once daily. For kids, you can see here that there's a range depending on their weight. And then we treat 6 weeks for fingernails and 12 weeks for toenails, and that just reflects the length of time that it typically takes the nail plate to grow out in those different sites.
It used to be that they would do it like this for 12 weeks and leave them out like once every other week or once a week for months after that. Is that gone now?
Yeah, not so much. So, I have a hard time counseling or encouraging my patients to do terbinafine, especially for toenails, just because the teaching that I learned in residency was if you take 100 patients who have onychomycosis of the feet, for instance, and you treat them all, half of them it's going to be treatment failure. Of the half that respond, half of those are basically going to get reinfected within a year, and so you're kind of back at square one. And so, I'm just kind of like, if the world's not seeing it, it's not bothersome. And that's partly it's a value judgment for the patient and for you to help them, work them through that. The other thing, though, is that there are conditions, so patients who have diabetes, for instance, and they're more prone to infections, they have poor vascular return down there. Those you really want to treat, even something like Tinea Capitis, because that can serve as a nidus for infection for a bacterial infection that will then be devastating for them. So there are different reasons where I would be willing to, but typically the patients who need it are the ones who have more complications, and then I'd be like, okay, maybe we should check it. But this idea of just kind of keeping them on it, I think, is not something we typically do. Well, when we talk about the different immune deficiencies, I think that there's just a big population of people who are more prone to dermatophyte infections in addition to things like Candida, and we just don't have a gene for it. But I think there's a lot of people who, are susceptible for it, and it'd be interesting to know if they have a common gene that's involved in that. Okay, so in children, oftentimes I'll have families come in and they'll say, little Susie has had this bump behind her ear, and it's been there for 3 months, and it seems to be getting larger, and then it's getting smaller, and sometimes it seems like there's another one behind the other ear. And when I see that, then the first thing I do is look in their scalp, because it typically is a manifestation of Tinea Capitis. So what's going on here is that we have the erythema, the scale that goes along when you have dermatophyte infection of your scalp, and the key takeaway here is look for lymphadenopathy. So if you're just seeing scaling and redness throughout the scalp, it could just be that the patient has seborrheic dermatitis. But typically, if you notice that there is significant lymphadenopathy, that's going to be a tinea infection until proven otherwise. The other thing to know is when you have patients who have curly hair, so typically in our African American populations, these patients are more prone to getting tinea infections, and it's just something, the way that their hair is curled and the coarseness of it, it makes it easier for the fungus to hold onto it, and that's in contrast to head lice, where the lice like straight hair better. So typically my Caucasian patients have head lice, and my African American patients are more prone to having the tinea infections, but that's really a function of how the hair is in these different populations. This is another example of Tinea Capitis. So you can see in this child's scalp that there's this background redness and then this really significant crusting throughout. When you see it to this degree, certainly psoriasis is something else that I would think of. But another clue in this particular instance was this rash that he developed here. So if you look really closely, there are these monomorphic little skin-colored bumps that are throughout his entire back. And they're extremely itchy. And this is something that we call an id reaction or autoexematization. And basically what it reflects is that the immune system is getting so revved up by the Tinea Capitis on this child's scalp that is causing sort of a sympathetic reaction on the rest of his body. So again, this is an instance where the patient didn't come in for this. They're just like, oh yeah, he has really bad dandruff. But they were wondering what these bumps were. And then I looked at this and I thought, oh, this is actually probably Tinea Capitis. Did a culture, it was. And treating the tinea will then also treat the id reaction as well. This is another type of Tinea Capitis called a carrion, and basically what this represents is that you have the fungal infection there, but the immune response is so exuberant that you get this boggy, crusted, inflamed mess, essentially, and often there's a bacterial superinfection as well. So my rule, which I think that I may have discussed at previous talks with you guys, is when in doubt, just culture. And if you're not sure whether it's bacterial or fungal, just send both. And I think it's never wrong. But this is an instance when you're looking at it and you think, geez, this looks really exuberant. You can see the associated alopecia, the inflammation here is so intense that there's significant hair loss as well. When you see that, definitely I would be sending a bacterial culture in addition, because that's typically the thing that makes it so inflamed and painful for patients, and that's something that you can intervene on really quickly, and within a few days they're already going to start feeling better, even though the duration of the therapy is going to be for treating the tinea that's there as well. So overall recommendations for treatment, again, the first one is just culture. So dermatophyte culture, bacterial culture, first-line treatment, and one thing that I'll do, even when I'm waiting, if I'm a little bit unsure, is this seborrheic dermatitis, is this Tinea Capitis, is just sending them home with either Selsun or ketoconazole shampoo. And the prescription strengths are 2.5% sodium sulfide or 2% ketoconazole. And the thing with this is also just to make sure that the families use it correctly. So they need to be using it ideally every day to every other day. And they should really lather up the scalp and then let it sit there for 5-10 minutes. It's important to let them know that it's not a shampoo that you're giving them. So it's a shampoo formulation, but it's not meant for their hair. It's really meant for their scalp. So they should put it on first thing when getting into the bath. And then the last thing they should do before stepping out is rinse it off. And that really gives it medication time to penetrate. If you have focal areas, it's totally appropriate to consider topicals as well. But typically when the hair is involved, the dermatophytes can go deeper into the hair follicles, so it might not penetrate. The exception to that are infants. So with that population, their scalp is still thin enough that typically a topical will work. And we like that as well because we don't love giving babies systemic medications if we don't have to. As far as the typical treatment, griseofulvin is always my first choice. I never do any lab monitoring for it unless they've been seen by a provider beforehand and have already been on 1 or 2 courses of Griseo. Then I'll check the ALT just to make sure that things are okay. But this is a 20 milligram per kilogram per day using the micro-sized version of the griseofulvin, and it's daily for 8 weeks. And it's really important to hit that target. If patients are underdosed, they will not respond to it. So you really need that. And encouraging them to take it with a fatty meal because the medications absorb better. So having them take the medication with some ice cream or some peanut butter or a glass of whole milk, things like that will be helpful. If Griseo doesn't work, terbinafine is my next thing that I reach for. I do that daily for 4 weeks. Again, in children, I will check an ALT at the beginning. If they've done well, I usually don't check it at the end of therapy, but I will check it beforehand. And the dosing is the same as we had discussed on the previous slide. And then if those fail, then considering things like fluconazole is reasonable as well.
And the dose is 250 milligrams per kilogram per day?
Oh, sorry, it's not per kilogram. Thank you. I'll change that. It's just 125 to 250 milligrams per day.
Okay, that's a lot.
That would be a lot. Thank you for pointing that out. And then for carry-on, again, if you think that it's looking crusted, you're sending a bacterial culture, it's totally fine to go ahead and start them. I reach for Keflex first. It's typically not something like MRSA where you need clindamycin or Bactrim. But it's worthwhile to go ahead and do that. The use of prednisolone is a little bit controversial. some people reach for it all the time. They just want to be able to calm down that inflammation. I typically don't because I don't want to prevent the immune system from doing what it's supposed to do. And in fact, the majority of what we're seeing there with the carry-on is a productive immune response. We want it to be doing something, but it's helpful to just kind of get rid of the bacteria and let the immune system calm down. But for patients who are in extreme pain, it's not unreasonable to consider doing that as well. And then finally, with the id reaction, like the adolescent that I showed you before, topical steroids is really all that you need to kind of help with the symptoms there. I usually reach for a mid-potency one, so one that's a class 4 or 5, so triamcinolone 0.1% or 0.025%, and have them put it on twice a day for about a week or so until the reaction passes.
If you biopsy that id reaction, what do you see?
That's a good question. I honestly have no idea. I've never biopsied an id reaction before. I imagine it would just be a lymphocytic infiltrate. That would be more perivascular, but I don't know for sure. Okay, so now we're going to get into more of my favorite things, because I like mechanisms. That's just how my brain works. And so I hope that you will join me for this, because I think it makes what we're going to discuss next a lot easier to understand. And we'll give you a framework for thinking about fungal infections in PID. Okay, so this is an example of the different T cell lineages that occur from a naive T cell. And the first one that I want to point out down here is the Th17 lineage. So what we know now is that Th17 cells are really important for mounting an antifungal response in our body. And this is shown in dermatology every day. We now have anti-IL-17 monoclonal antibodies that we use for psoriasis, since the Th17 axis is also really important for that condition. And the big side effect with these patients is that they get candidal infections. So just kind of pointing out the main players here. So in order to push a naive T cell towards the Th17 lineage, the different cytokines that we need are TGF-beta, IL-1, IL-6, and then IL-21, IL-23, and IL-22 are other ones that are involved in kind of pushing things along. And I just want to point out STAT3, which is a transcription factor that's essential for this lineage. Okay, so that's Th17. And then up here we have the Th1 lineage, which we all know is promoted by exposing naive T cells to IL-12 interferon gamma. And STAT1 is an essential transcription factor for this process. Okay, so I just want you guys to keep that in mind as we go forward. Okay, before your eyes glaze over, we'll take this step by step. But this is looking at signaling that promotes a Th17 response. Okay, so we have 3 main cell lineages here and their responses to it. So we have the macrophage, or the initial responders to any infection, Th17 cells, and then the effector cells that they act on. So with macrophages, this is one of our first lines of defense against cutaneous fungal infections or fungal infections of any sort. And the cell receptors I want to point out are TLR2 and 4, and then the dectin receptor. And you can see that they are reacting against different proteoglycans that are present on the surface of fungal cell walls. And specifically O-linked mannan, and then the alpha and beta glupins are things that are recognized by our immune system to help stimulate an immune response. And when we signal through these toll-like receptors or this dectin receptor, the big response is that it's pro-inflammatory. So we're upregulating NF-kappa B. And then down here, we're going to start to generate the IL-1, the IL-6, the IL-23. Again, these are all cytokines that are important in generating a Th17 response. In contrast to that, if a macrophage is exposed to interferon gamma, we have upregulation of STAT1, and then that causes an inhibitory effect on this pro-inflammatory cascade. So this is actually an antagonist of that response. And then again, in the Th17 cell, I just want to point out that we have STAT3 here. So sorry, again, when you have signaling through these two, you get a pro-inflammatory Th17 stimulating response. When it goes to interferon gamma instead, then it blocks that response. Okay. So there's lots of different immunodeficiencies that are characterized by chronic mucocutaneous candidiasis, and the more that we learn about them, we're now sort of separating them out based on their genetic underpinnings. So one of the most common or the most well-studied forms is chronic mucocutaneous candidiasis from STAT1 gain-of-function mutations. So the idea here is that we have increased interfering gamma signaling, as I kind of had mentioned in the previous slide, that causes decreased production of IL-17 stimulating cytokines and then decrease in Th17 cells. And what that ends up resulting in is an increased susceptibility to Candida and dermatophyte infections. And sometimes you can get other fungal infections as well. The other things that are hallmarks of this condition are bacterial simopulmonary infections, impetigo and viral infections, and then they have a propensity for autoimmunity as well. And so this manifests primarily as hypothyroidism and insulin-dependent diabetes type 1, as well as other cytopenias and other things that I would see in the dermatology clinic like vitiligo, alopecia. The other manifestations of this can include psoriasiform dermatitis or psoriasis. These patients are prone to malignancy, so they can get cutaneous malignancies or pharyngeal, esophageal tumors, as well as leukemias and sometimes melanoma. One thing that has been more recently recognized in literature is that these patients are more prone to getting aneurysms of the central nervous system, and they'll have dental anomalies, problems with the GI tract as well. Okay. So in my thinking of this, right, if we go back to this, right, so we have the STAT1 gain of function, so we're pushing things kind of along to this Th1 phenotype. And again, down here, when we're promoting STAT1, we're inhibiting the Th17 phenotype. So that's kind of, there's the immune imbalance because the way that this transcription factor is overactive. And looking at that, if we're stimulating the Th1 response, the big thing that I was wondering was, well, why are you more prone to things like VZV infections, right? When you think about fungal infections and viral infections, it's often a Th1 response that stimulates the effector cells to rid our body of those. And the thought is that there can be antigen-specific just exhaustion. So these cells are being exposed to HCV, VZV when they have overactive STAT1 signaling. There may be problems with internalizing these different signals, and you just get energy and exhaustion from that, which leads to those types of infections. But again, the fungal infections are due in large part because this deficiency of Th17 cells or a relative deficiency. But that explains why those two things go together. As far as the autoimmunity, the thought there is that there's a shift, and again, this is a little bit hand-wavy for me because I don't know the details of the science behind this, but that there seems to be a shift towards a type 1 interferon response instead of a type 2 interferon response, and lots of different autoimmune diseases are associated with increase in interferon alpha and beta signaling. And so that's the thought as to why they had increased autoimmunity as well. So these are just some examples of patients who have STAT1 gain of function mutations. And again, so this patient has Tinea Capitis, and looking at it, right, so it has this nice annular look to it. You can see that it's raised and scaly. There's a little bit of clearing here. I would not walk into a room and be like, this has to be tinea at the end. This is something where I would consider if it could be a form of like nummular dermatitis or psoriasiform reaction, and before treating it, I would definitely scrape it just to make sure that it was fungal in origin. When you see this in the context of this, so this patient has really significant onychomycosis, definitely that kind of pushes you more in that direction. But a case could be made too that this is psoriasis, and maybe you just had some dystrophy of the nails from psoriasis. So again, culturing is such an important part of what we do to confirm the diagnosis before just launch into treating them, and that's why I'm a big advocate of that.
How often do you get a super infection with fungus when you have dead skin like this that's just there?
Yeah, so, well, what do you mean by super infection?
Like you said, you wouldn't think of that as fungus, you'd look at it as psoriaform dermatitis or something else.
So you mean like a fungus super infecting a psoriasis, for instance?
Correct, or any other lesion, like the nails.
Yeah, so that typically doesn't happen, and the reason for that is the Th17 response that's associated with psoriasis actually causes an increase in bacterial and fungicidal peptides from the skin surface itself. So that's why, whereas when we have children with eczema, they're more prone to getting lots of super infections. Psoriasis rarely, if ever, gets super infected. So that's the one thing that's nice for us as providers. It's going to be one or the other, and not a super infection of one onto the psoriasis, for instance.
Is the age of onset going to be different if you have a primary immune deficiency? Will you get this much earlier in life than
Yeah, so it would be more extensive and earlier in life. You know, as I showed you with that one picture of the baby who had the tinea facie of the scalp, right? So even for people who have completely normal immune systems or normal in the developing age, right, you can get them, but something that's persistent and recurrent recurrent and extensive should make you think more about a primary immunodeficiency driver, especially if it's in the context of other infections. So this is a patient that Eric Allensbach and I followed together. So he has a documented STAT1 gain-of-function mutation. It's in a new, the mutation is a new one that has not previously been reported in literature. And I bring him up because he is somebody that I think is going to kind of like push our knowledge of this a little bit further as well. There's lots of things about his presentation that are a little bit unusual to us. So he's had the sinopulmonary infections, he's failure to thrive. He lives in Portland and comes up to see us every few months. And last year he actually had an aneurysm, and so he was part of that he displayed that phenotype as well. As I mentioned, we often see psoriasiform dermatitis in patients, and so he came presented with all these red splotches all over him. But they really lack kind of like the scale and the thickness that I normally associate with psoriasis, so I wasn't sure if that's what it was. And we ended up biopsying him, and it just showed that there was a perivascular lymphocytic infiltrate, so it was a very non-specific. It did not look like psoriasis under the microscope. And so he is someone who's kind of like a work in progress as we try to define his clinical phenotype a little bit better. But just to say that I think that there's lots of opportunities to keep on learning and lots of new things that we're going to be understanding about this particular disease and lots of primary immune deficiencies in general. And I feel really fortunate to be able to work with people who can figure those things out. And I just had to tell them what the skin looks like. But seeing a rash like this, if there was more scale to it, then that would be more consistent with the psoriasiform eruption that you see with STAT1 gain-of-function mutations. So this is another example of Tinea Capitis. And I point this out because this is really extreme, right? Like if a patient came into your clinic and you saw it, you'd be like, holy moly. And again, even if the patient has a known diagnosis of STAT1 gain-of-function, I think all bets are off as to what this could be, because certainly you can get a like vegetating fungal infection that's just been untreated for a long period of time. But if you remember in my initial slide on this condition, these patients are also prone to cutaneous malignancies, and a squamous cell carcinoma can look just like this. So this is something that absolutely needs to be biopsied. And if you biopsy it and send it to pathology and tell them to do fungal stains, this will be just chock full of hyphae everywhere. So the good news is that this is actually, I can't remember, I think this is the daughter and this is her father, and they were treated with systemic terbinafine for a number of months, and you can see that everything just kind of melted away. And this is, again, sort of harkening back to that moccasin distribution of the Tinea Capitis, and this is the interdigital Tinea Capitis that has just run amok and gives you these massive fungating lesions. But fortunately, this is all just fungus, but super impressive presentation. And then again, just as a comparison, this is what a squamous cell carcinoma looks like that has been unchecked for a number of months or years. And you can see that there's lots of similarities where you kind of have this lobulated surface, it's a little bit glistening. There's erosions and breakdown. So, distinguishing between the two clinically is a fool's errand, so it's just best to get a piece and send it off. This is just another example of a patient who has CMC from STAT1 gain-of-function mutations. Again, you can see that there's significant dystrophy of the nails. This is referencing the chronic candidal paronychia that's affecting the periungual areas and then causing dystrophy of the nails themselves. This is a little bit of candida involvement of the scalp with some thicker, greasy scale, and this is candida as well. So as far as treatments for this, so traditional antifungal measures, a lot of these patients will need systemic antifungals. The nice thing is that we actually have a gene therapy, or a targeted therapy for overactive STAT1 signaling, and that's Jakafi or ruxolitinib, and this dosing is based on weight as well. The patient I share with Eric, he and I, we have our patient on Jakafi, and interestingly, his skin rash seems to be getting better. He had some diarrhea and is starting to put on a little bit of weight as well, so it seems like it's helpful for him. But it's nice to know that if you have this immunodeficiency that's caused by a overactive gain-of-function mutation, you actually have a medication that you can use that can reverse the phenotype. There's other reports in literature of patients who have alopecia areata associated with STAT1 gain-of-function mutations, where the alopecia areata was cured by use of these STAT1 inhibitors. Okay, so we're going to be moving on to other manifestations of CMC, and I just want to bring us back here to this dectin mutation. So dectin is on the surface of macrophages that helps to identify different fungal cell wall proteins. And dectin specifically is a beta-glucan receptor. And there can be different variations as far as this mutation. It can be actually a non-functional one, or it can be poorly expressed. But the bottom line is for both of these, we are decreasing those cytokines that are important in generating a Th17 response. The thing to know, though, is that those cells that are present and can actually phagocytose different fungi will do that appropriately and normally. So this condition is marked by recurrent or chronic vulvovaginal candidiasis. Sometimes you can get oral and esophageal candidiasis as well as involvement of the fingernails. So when you see it, when it's just limited to those few things, but it seems chronic or recurrent, think about a dectin-1 mutation. We're going to contrast that to some other conditions. So down here we have CARD9. So this is a scaffolding protein that's downstream for the dectin receptor that sort of mediates this pro-inflammatory response and allows for the expression of these cytokines. And this is another autosomal recessive condition associated with CMC. And the thing about this is that as an adaptor protein that's downstream, it's also involved in other signaling. And so this is downstream of the complement receptor 3 that's really required for neutrophils to be able to destroy Candida species as well as dermatophytes. So these patients will get the same thing. They'll have their superficial Candida infections, they'll have dermatophyte infections, they'll have envelopment of their nails, but they are also at risk of invasive Candida and dermatophyte infections. So when you see this, it's a whole different ballgame, and this next picture will demonstrate why. So these are all dermatophytes. This is trichophyton, a trichophyton species, and again, we're getting the same thing like in our STAT1 gain-of-function patient, where you just get this like fungating, rip-roaring mass. This is what like if you have Tinea Capitis or ringworm, this is what it looks like when it becomes invasive, and it's no joke, right? So when you see this, again, this requires biopsy, this requires sending for cultures. If you notice that that the species that's doing the invading is a dermatophyte, the first thing that you should be thinking of is a CARD9 mutation. Treatments for these, so systemics, as needed. At this point, I don't think that there's any recommendations for just chronic sort of prophylaxis, but certainly any sign of an infection should be aggressively treated. And because the neutrophils are so affected in this condition, it's been suggested that these patients should get GM-CSF as well.
It's curious to me, you would think the CARD9 is downstream from dectin, so I would just think something more upstream would lead to a more severe phenotype than something downstream.
Yeah.
But it's the opposite.
Yeah, so the thing that I think, so when you have the upstream, right, and I guess, it's very simplified in this particular schema where you're just looking, okay, so this affects this, affects this, affects this, and sure there's multiple other signaling pathways that are probably being activated by dectin, but the key that's not being shown here is that with the CARD, you're missing the CR3, so this can be downstream of multiple, it can be an adaptive protein for multiple signaling pathways, and so you'll have one thing that's being involved here, another one that inputs here, or maybe the CARD9 is associated with other proteins, and so there's a completely different signaling pathway. So that's how I see it. It affects more because it can be downstream of multiple different receptors. Okay, and so now we're going to move more into the IL-17 family itself. So defects in the IL-17, either receptors or the IL-17 proteins, are now considered to be CMC disease. And typically the mutations are in IL-17 receptor A and ACT1, which are both autosomal recessive, and IL-17F, which is an autosomal dominant condition. So there's multiple proteins in the IL-17 family, A through F, and multiple receptors. The thing to know is that for all intents and purposes, the ones that matter are IL-17A and IL-17F, because those are produced by Th17 cells, and then IL-17RA is the common subunit to every single IL-17 receptor, so that's sort of the one that we care about, because there's so much functional redundancy between the other ones. So if you have a defect in IL-17F, you just get chronic mucocutaneous candidiasis. If you have one in either the autosomal recessive form, so IL-17RA or ACT1, which is one of the scaffolding proteins, then you get CMC plus staph infections. And this is one that I don't understand why, except to kind of give a hand-wavy answer that there's lots of redundancy with the IL-17F. So for instance, you'll have IL-17A, but if you're actually interfering with IL-17, the receptor itself, you may be more prone to other infections. But again, I don't have a great, clear explanation. I couldn't find anything in the literature as to why these patients are more prone to staph infections as well.
Can you measure IL-17 like we could just order a lab
Yeah,
test?
I think they have assays that you can do like flow or something for it. I've never tried it myself. Probably, I don't know. Did you ever order that? Have you guys ever ordered with like Troy or
Troy
Suze
used to
or-
run it. He doesn't run it anymore, I don't think, but he used to
Yeah.
do that.
So
So if these people respond to any fungal therapy, is there any reason to send them to you, or just to qualify them further?
yeah, I mean, so this kind of with the CMC disease, my guess is that there's tons of people that are out there that have CMC disease, or just more prone to like dermatophyte infections, and just kind of like, well, that's my lot in life, and I'm going to treat it. So as long as there's no other like complications, certainly if they're getting like staph infections or the invasive, those are other sorts of things. But I don't think that for the way that I kind of approach this is I'm happy to be a part of it as a dermatologist to help like make the diagnosis. And I'm happy to, for something like that, I'd be happy to do the treatment as well. I'm not sure how much utility there is in being like, oh, like let's send off the genetic testing, right? This is a condition that's probably not going to harm anyone's overall quality of life, and unless there's some other comorbidity where like knowing that diagnosis is going to make a difference, I think a lot of insurances probably balk at it as well. So know that I'd be happy to see any of them, but if you feel like you can dose the antifungals, they don't need me. So. The other thing too, and I tell this to my family, is when I get referrals from you guys or any other provider, sometimes it's just kind of like you want the dermatologist input to be like, hey, like we agree, or like, hey, we think that this is it. And I let them know, I'm like, if it makes sense for you to come back to see me, I'm happy to see you. But I know that your, allergist, your immunologist, your pediatrician, whoever can take care of these things as well. And if you're comfortable just seeing them for it, that's fine with me. So for this, fluconazole is typically thought of as the first-line option. Prophylaxis can be used, and then using other azoles like Posa or itraconazole as well. I will just mention again, I think I may have in a previous talk, we don't like voriconazole in dermatology because it's photosensitizing in patients who are on that. And typically it's their bone marrow transplant recipients. They are more prone to getting squamous cell cancers, and so you don't want an immunosuppressed patient being more prone to getting cancers because it's just a bad mix all around. And then considering back from prophylaxis if they're having standard infections as well. Okay, so just pointing this one out again now. So remember that STAT3 is really important for Th17 cells, and these cytokines, again, are necessary for that. And specifically, the IL-23 receptor. So IL-12 receptor beta deficiency is also associated with CMC, and IL-12 receptor beta, in addition to being part of the IL-12 receptor, is part of the IL-23 receptor. So because of that, these patients have a relative deficiency in Th17 cells as well. So the IL-12, as I mentioned here, that's really important for type 1 or Th1 responses and interferon gamma signaling, and IL-23 is important for Th17. So these patients have a mix of phenotypes. One is they're showing that defect in Th1 responses, so they have increased risk of mycobacterial, salmonella, and intracellular pathogen infections. But then a subset of them also will have candidiasis because their Th17 axis is compromised, and often that candidiasis is the first presentation. And what I showed down here is just kind of the relative instance of these. So usually it's an oropharyngeal or vulvovaginal candidiasis that goes along with it. As far as proposed therapy for this, the first episode typically is just you give them some fluke for a few weeks. If the candidiasis is persistent, you can extend that course or consider switching azoles. And then if there's no response to that, then considering ampho or echinocandins. When you have limited to vulvovaginal disease, then standard treatments are typically enough. And primary prophylaxis is not recommended, but if you have patients who are recurrently infected, then doing secondary prophylaxis can be done. Okay, so the last two things I'm going to go over are a little bit of a refresher, because I spoke about these last year when we were discussing different eczematous dermatitis or dermatoses as well. But I want to touch again on APECED, or autoimmune polyglandular syndrome type 1. So this is a defect in air. Typically it's an autosomal recessive mutation that predisposes to a classic clinical triad of CMC, hypoparathyroidism, and Addison's disease. And so the reason that these patients get CMC is because when you have this break in central tolerance, you start to develop antibodies against IL-17 and IL-22, which makes it difficult to mount that Th17 response. And these patients will have diploid dermatitis when they're young, thrush, esophagitis, angular cheilitis, when you see kind of just redness and fissuring of the angles of the mouth, and then they're prone to getting nail infections as well. In addition to that, they have a whole host of other autoimmune symptoms or other autoimmune diseases like vitiligo, alopecia areata. They can get urticaria, and then they will have involvement of other appendages as well. So they have dental enamel hypoplasia, conjunctivitis, and then the nail dystrophies, and sometimes they can have salivary gland inflammation as well. So this is a patient who has APECED. You can see that they have the oral thrush associated with their CMC here. This again is an example of Candida carinacea. And then throughout the scalp, you're starting to notice that there's a little bit of vitiligo here, and the poliosis that's going on around here is the early signs of vitiligo or perhaps even alopecia areata in this patient. This is an article that came out from the JCI about 2 years ago now that proposed an alternate classification or diagnostic criteria for APECED. So in addition to the classic three of the CMC, the hypoparathyroidism, and the Addison's disease, they also described dental enamel changes, any sort of like enteritis, and then an urticarial eruption. We'll just kind of focus on that a little bit more. So again, with urticaria, what you're seeing is redness and a little bit of like some raising of the skin, but you're going to be missing that overlying scale that often goes with eczema and other dermatoses like that. So if you see something that that looks like a hive, you're in business. And the reason that makes a difference is the classic like making the diagnosis on clinical grounds requires 2 out of the 3 of the classic triad. However, when you include these other 3 and you look for 2 out of the 6 criteria, you're able to diagnose these patients about 3 years earlier, so between like 3 and 4 years of age instead of 7 to 8. And often it allows physicians to identify the disorder before they present an Addisonian crisis. So keeping those other diagnostic things in the back of your mind can be helpful when you're evaluating a patient with CMC as well. And then we're going to finish with STAT3, loss of function, autosomal dominant hyper IgE syndrome. Again, I don't want to belabor this too much since we spoke about it at length last time I was here. But these patients are having really severe, what's described as an atopic dermatitis-like eruption, as well as getting sinopulmonary infections, more invasive skin infections like abscesses, and they're prone to bone infections as well. The eruption is not really typical for atopic dermatitis, and that's again the key that I would want to emphasize. So with atopic dermatitis, when you have an infant that comes in, they typically will have just involvement of the cheeks, where you're going to see often an exudate kind of like wet weeping look to them and background erythema. In this particular condition, they have a papulopustular eruption, where you get these small individual papules and pus bumps that typically involve the forehead, and then there may be extensive involvement beyond there. But they lack a lot of the other signs of atopy as well. Other things to look for: hypersensible joints, if they retain primary teeth, a high arch palate, or what we describe as a coarse facies, then those are things to make you consider hyper IgE syndrome as well. The IgE levels can vary though, so I wouldn't hang my hat on that diagnosis, especially because IgE can be elevated in lots of different conditions, from atopic dermatitis to Netherton syndrome to a whole host of immune deficiencies. So again, looking at this, what we have is a loss of STAT3, and that means that we have no Th17 cells. So if you were actually to do flow cytometry looking for Th17 cells in patients with autosomal dominant hyper IgE syndrome, they will be absent. And again, this is just an example of that papulopustular eruption. So you can see that the patient has some cheek involvement as well, but it's a really significant involvement of the forehead, and it's individual lesions, as opposed to this patient, which is a classic atopic dermatitis, where you see this nice headlight sign. And again, it's eczematous, it's red, it's flaky, and it's involving the cheeks, but his forehead is completely spared, and it's not these individual bumps. So that's the key again. A rash is not a rash. There are differences that can help point you in one direction versus another. And then this is again the same patient as in the previous photograph, where they have involvement of the diaper area, which is typically a site that's spared for atopic dermatitis because it's nice and moist. And it's individual bumps that have been aggressively scratched at, so you get this lichenification or thickening and darkening of the skin in those areas. It's just an example of an abscess or two adjoining abscesses on the forehead of a patient. And then kind of summarizing all the things that we see in autosomal dominant hyperIgE syndrome. So again, the papulopustular eruption, this really pruritic, lichenified eruption that can be in areas that are a little less classic for eczema. The coarse facies with kind of blunted angles of the nose. The skin often has like a doughy kind of like prominent cord appearance. This is a high arch palate and two signs of hypersensibility. So this is what we call Gorlin sign. If you can touch your tongue to the tip of your nose or bend your fingers in all sorts of wacky directions, then definitely be considering hyper-IgE syndrome in these patients as well. Okay, that's it. I'm going to take any questions.
I'm glad you know all this stuff.
What disease?
We know who to contact when people look funny.
Is this a hyper-IgE duck syndrome?
That's a little levity of human presentation.
All right, thank you again. Sincerely, good to know someone in town knows all this.
Yeah, no worries. I'm here for you.
How common is this IL-17 defective cells? I mean, if you look in the general population.
Yeah, that's a great question. I don't have any numbers for that. And again, my guess would be that it's under-recognized. I think it would just like, oh, you know, like, okay, it's your, like, ringworm again, or it's your candida infection. And when it's frequent, you know, in the general population, if you think of, like, pediatricians or dermatologists, a lot of us just don't know this stuff. So the people who are going to be seeing it first are not going to be like, oh, like, this is my third, like, ringworm. They're just like, gosh, I have horrible luck. It must be the dog that I have at home. So they don't think, like, oh, maybe I should see an immunologist about it. And we as providers, unless you're thinking about that, you just kind of like, oh, okay, well, I guess it is what it is. Let's think about, like, decolonization or, like, how we can, like, help you wander your clothes here less prone to. So my guess that would be underreported, and especially when you think of, you know, from an evolutionary standpoint, there's not a whole lot of, it's not so debilitating that there'd be a huge shift away from it, I would guess, but yeah, I honestly don't know.
Just the only way we can get approval for long-term use of any of the imidazoles, except for Lamisil, is to say they have chronic mucocutaneous candidiasis, which is not a single disease. That you've convinced me. But they usually, now they give you one diflucan pill. And then if you want more than that, you have to come up with a disease that actually will allow that.
Yeah, well then I guess then it'd be super useful to have that information. Of course, then you have to get the insurance company to pay for the genetic testing. But I think too, you know, if you didn't want to do that, I think that saying like, you know, if it's truly recurrent, I would say if you're having like 2 or 3 within like a year or two, like timeline, I mean that's a lot in my experience. And again, like my experience is probably much less than your guys when it comes to things like that. But I think that alone, I would say like this is consistent with the diagnosis of it. We know that it's a monogenic disease. We know there's lots of different possible ones. So if you want to pay for the genetic testing to get the diagnosis, great. Otherwise, like this is probably what they have. And I have to say, when I provide literature that kind of like talks about like these different diseases, and you have someone who's like normal on the other end, and sometimes you can get a peer-to-peer, they'll usually approve that sort of stuff, but it does require a lot of work, and it's frustrating to do that.
And treatment doesn't really change. You just can justify your treatment.
Why you're getting it.
Wow.
Thanks again.
Yeah, you're welcome.
Alrighty.
I don't see kids very much.
On like CNN and
Never really organized.
CMC though, that can take 2 or 3 months.
yeah.
They always get
That just happens in like
how frequent do they have to be before you send them back?
Maybe it is time.
So I was always curious if they have this chronic these people with any fungus respond to this? Don't it? That's what I was going to ask you.
should talk to Lisa Winter about that. Because she told me that she's been publishing some stuff that still has some stuff.
As soon as you walk out the door.
Yeah, he actually told me.
But the pictures I remember here, see your friends if you wrap. That's what it is.
So I was talking to her, it's like,
He's like,
pretty
what's
far
I was like, wait,
along.
so he was like,
All right,
oh, yeah,
Thanks for letting us sit in. Nice meeting you.
Anytime.
I don't know, it was like, but he also was like, director from that.
Thanks for letting us sit in this morning.
Any
That's right.
getting blood sample,
Yeah. 31 people responded.
I haven't responded yet because my computer wasn't able to respond to your catalyst. Send that to my own computer.
I'm going to have her send it again because she made a mistake. She didn't identify by name.
What I even do.
You
And then he did.
Have a good one. You have them suffer.
Yeah.
I can't do it.
Yeah. So
You would just have to tell me and say, oh, but
How
she
many
can do
clicks?
it.
I'll keep doing it as long as I
but he,
can.
yeah. It was
Honestly,
the
just
first
like
one.
one. Like, so
Like one full.
yeah, so
I
she
really
got
enjoyed it.
one.
No, I know. So actually, Dad was like, "Can you admit him to this?" Like, I was like, "What I told him is I'm gonna send this to him,
Yeah.
and there's 12 genetic tests on this man.
Yeah.
Maybe we'll get the money.
Yeah.
We'll let you know."
I'm gonna do more clinical than I think like Jake or Andrew did.
Yeah. So it was also friendly. It sounds like we'll have some Dan, and they didn't get the exact biopsy they wanted.
Yeah.
And
Who
he
else
was
is
like,
gonna
"Well,
give you
he's not gonna biopsy," and he was like, "When we tried by Jake, he said that I wouldn't be able
All right,
to
we'll
want
keep
to like go to
talking it
I
out.
keep chewing on them.
Yeah.
All right.
he said. So,
Yeah.
so he's like, can you admit him? If you rate him, you could biopsy. And I was like, I don't know. I'll talk to him.
Yeah. Well, the other thing too is that like
I would talk
to
to Dan.
do that, there has to be a certain amount of advanced planning, right? And
Whatever
that means
whatever
it's
you're
fine.
interested in.
Are you guys
Right. So that's sort of the hang up too.
Well, they usually last like 10
Sometimes, yeah. Like, I mean,
But by choice.
Sometimes more and more.
You guys take any food that you want. Otherwise, I gotta find a home for it.
It's just like what's in your own time.
yeah, it's more just like somebody said this year that they're. I'm okay. Thank
I
you.
don't want to interrupt. I have 1 second question. We just keep going. With the CMC,
Troy's busy, but like if you're there physically, you can kind of get a hold of him. So it kind of is up to you. Like, you can still talk to him about if he has ideas. I think Jake was worked with him last year. He started.
Sorry to interrupt.
You all go into the meeting?
Yeah.
Okay. Did you get an invitation to the presidential
Yeah.
session?
Yeah.
And there is a talk this Thursday. I think you can go to commercial talk if you're still permitted as a fellow.
But are they like this? Or are they like why?
No, they're
really
like
shouldn't.
1 centimeter
Yeah.
top.
Nobody
Yeah.
seems to
And
believe
they
you
were not
take
why.
it.
Yeah.
They're 1 centimeter top,
So,
but
I don't know if
but
you signed up
they
to
look
I
this.
have
like
it,
parents
yeah.
were like when I
I mean,
walked
you're
in.
welcome to if you
Yeah.
want.
And then I
When
saw
they've had
some
people
of them
come to
that
town
turned
to
darker.
talk about
Yeah.
that
Some of them had
before, they've
scarred,
been
Yeah.
and I was
derm
like,
people. This guy's actually an allergist, so
Yeah.